I'm going to hand over at this stage to Michael Mack, our 2015 Maggie Yacoub lecturer.
Thank you very much. And Doug, thank you for that very kind introduction. This is a double honor for me. This is my third time at this meeting, and I very much enjoyed it over the years. And it's a double honor, number one, to be at the 50th anniversary meeting of this great organization, and then secondly, to be able to give the Sir Maggie Yacoub lecture here. I was with him here 2 years ago, and I suspect that may be the video that will be shown tomorrow. But let me take care of some housekeeping items here before I actually get into the lecture. First of all, for clarification, I have checked, and this is Mark Allen. Mark, I'm sorry you got insulted by having my picture taken. I've also checked, this is me. And although we both wear glasses, Dr. Prager also wears glasses. This is him. Now, the other thing I would say, Dr. Prager, is I did get the memo that this was casual, and I do not have a tie, unlike you. So this is a casual meeting, and that means no tie. I also had the opportunity this year of being a visiting professor at both the University of Michigan and the Ohio State University. And I very much enjoyed both. Now, Dr. Higgins was still at the Ohio State University when I was there, and he arranged for me to meet Braxton Miller. So, Rich, why didn't I meet Jim Harbaugh?
You want to come back?
Only if I can meet Jim Harbaugh. So, the talk I'm about to give is the current state of transcatheter valve replacement. And not all this may be a message that you want to hear, and I'm just here to tell it like it is, so don't kill the messenger at the end of this talk. So this is my conflict of interest disclosure. I am a member of the steering committees of 2 trials of transcatheter valves. One, the partner trial, and second, the COAF trial. Unfortunately, I wasn't compensated for either of these. So, the world of valvular heart disease is changing. Now, you may or may not like the way it's changing, but it is changing. This is an outline of the talk. I'm going to first of all talk about aortic, second mitral, and then at the end a few comments about transcatheter treatment of tricuspid valves. So aortic valves, there are 2 valves approved in the United States. On the left is the SAPIEN 3 valve of Edwards Life Sciences, a balloon expandable valve, and on the right is Core valve, now in its 2nd generation also with the Evolut R. Now, I had the opportunity of meeting this gentleman about a year or so ago, and if you're from the U of M, you can't answer this question. Also, if you're from the Cleveland Clinic, you can't answer this question. You may know who it is. Does anybody else know who this gentleman is? The one on the left, not the one on the right. All right, so this is Henning Anderson. Does anybody now know who he is? Richard?
Yeah, famous Anderson fans.
So, he is a Danish cardiologist that went to a vascular surgery meeting that Ted Dietrich put on in Phoenix every year. It was in the early 90s, and it was the stage where endovascular therapy of vascular disease was beginning. And so he sat there and listened to all about aortic stent grafting and things like that, and kind of said, why can't you put a valve inside one of these stents? So on a plane on the way back home from Phoenix to Copenhagen, he sketched out this sketch on a napkin, put it on a balloon, put together a delivery system for it, and filed this patent, as Dr. Sheeman just said, is the Anderson valve patent that was published in 1995. And to show the value of this patent, there was a patent infringement suit between Medtronic and Edwards a few years ago that was settled for $1 billion. Now, this is the valve that he came up with. He likes to say that this was the first heart team at work, because after he made that drawing, he went to his home institution, went to the operating room, and got stainless steel surgical wires for sternotomy closure, and crimped them in his garage, and that's the stent that you can see on the outside, and got a porcine valve and put it inside it, mounted it on a balloon that was used for balloon valvuloplasty in the cath lab, and that was the basis of transcatheter valve therapy. But it was somebody thinking outside the box of cross-fertilization, going to a endovascular and vascular surgery meeting and say, gee, why can't you do this? The story is very touching completion to it 20 years later, when this gentleman received a transcatheter valve in 2011 in Copenhagen. And what makes the story so touching is this was Henning Anderson's father. So how many times in life do you have the opportunity of kind of inventing something and it actually benefits somebody in your own family? So if we look at what's happened in transcatheter valve replacement and interventional therapy for valvular heart disease compared to an interventional therapy for coronary artery disease, when PCI came in, it was introduced into the lower risk, more straightforward patients, leaving the higher risk and more complex patients for surgery. What's happening in TAVR is just the opposite. In that TAVR has been introduced into the high risk and inoperable patients and leaving the lower risk, more straightforward patients for surgery. So as a consequence of that, we as surgeons should be benefiting from that by seeing our outcomes improve, because our higher risk patients are now being treated by an alternative method. And indeed, I do think we're seeing that that is true. This is the 30-day mortality for aortic valve replacement from the STS database, and it is now down to about 2.2% per year, a steady decline for the last 7 years right now. I think some of this is a consequence of transcatheter valve therapy, but not all of it. I think we are better at addressing these patients surgically than we were previously, especially through some of the minimally invasive approaches that Joe was mentioning. This is Wall Street estimations of what's happening in the United States right now. And this is the adoption of transcatheter valve in the dark red on top. And you can see that now there's about, as of the end of 2014, about 20% of the patients with aortic stenosis in the United States are treated with TAVR. The total number of patients treated is increasing about 8% per year, and surgical aortic valve replacement is still increasing as of the end of last year. It had a 2% growth rate per year between 2011 and 2014. I'm not so sure that's going to continue from here, however. To get an idea of what's going to happen in the United States, it's always good to look at Germany, which is about 4 years ahead of us in terms of this therapy. And this is patient age of patients that are treated with TAVR in the blue and surgical AVR in the pink. And you can see that there is a fair amount of overlap occurring on these histograms of patients overlap on the basis of age. And if you look at logistic Euroscore, which is a predictor of risk, again, you can see there's beginning to be a fair amount of overlap in terms of the risk of patients. The lower risk still going to surgery, the higher risk going to TAVR, but an intermediate group in which there's a fair amount of overlap. And these are the results in Germany that we can see that if you just do an isolated surgical aortic valve replacement, the 30-day in-hospital mortality, I should say, is 2.1%. Virtually identical to the surgical mortality now in the United States, and the transcatheter mortality is 5.1%. Again, it's different patients, different risks, but this is an idea of where the world is heading. Now, the partner trial, which was the original pivotal trial in the United States of transcatheter valve therapy compared to surgery, was presented at the ACC in March and published simultaneously in Lancet. And this is the 5-year results that show that at 5 years, the results are absolutely identical in high-risk patients with a 67% mortality at 5 years. So in my mind, tie goes for the runner here. A less invasive always beats more invasive as long as the results are identical or close to the same. And therefore, I think that TAVR has become the preferred treatment of choice in high-risk patients. Now let's look at intermediate risk patients, and this is a paper that was published by Vino Thurani earlier this year in January in the Annals of Thoracic Surgery that looks at STS database in 141,000 patients. And let's just look at the intermediate risk, which is the group in the center, and this is 2007 to 2010. The predicted mortality was about 5.5%, and the observed mortality was 5.4%, for an observed to expected ratio of 0.98. So what this means is the STS database works pretty well. The risk algorithm is very accurate because the observed outcomes are about identical to the expected outcomes. So why do I point this out? Well, this was a paper that was presented at the American College of Cardiology in March that looked at the results of the SAPIEN 3 in intermediate risk patients. So the average STS predicted risk was 5.3%. Remember, in the surgical series, it was 5.5%. The average age of these patients is 82 years old. Despite the fact they're intermediate risk, they're still in their 80s. 89% of these were done by a transfemoral approach. This is the outcomes. The all-cause mortality was 1.1% for an observed to expected ratio of 0.2. There also was a low incidence of stroke at 2.6%. So let's just look at this side by side and see if we can figure out what's going to happen here. So surgical aortic valve replacement, again, a predicted mortality of about 5.5%, observed mortality of 5.4%. About the same risk in transcatheter aortic valve replacement, about the same predicted mortality, but the observed mortality is 1%. So an observed to expected ratio of 0.2 compared to 0.98. So intermediate risk trial will be is completed. It's a 2-year primary endpoint that will be reached in January of next year. And then it'll be up before FDA for review by fall of 2016. I don't think it takes too much of a stretch to predict that TAVR will be approved for intermediate risk patients just on the basis of knowing this 30-day data from that trial. You have to have a lot of problems between 30 days and 2 years for these results to be neutralized or negated. So if we look at what's happening with transcatheter valve, this is just the SAPIEN valve, and the same thing can be said for core valve. I know a lot of sites in Michigan use core valve rather than SAPIEN. We grew up on Edwards SAPIEN, and that's kind of why I showed this data, because I'm most familiar with it. But you can see there's been a steady trend downwards in 30-day mortality from the initial trial in inoperable patients of 6.3% down to 1.1%. This again is another Wall Street publication. This is a survey of 25 cardiologists and 25 surgeons done in May, looking at their opinion right now what the role of TAVR is in intermediate risk patients. And interventionalists is in the center, surgeons on the right, the composite on the left there. And you can see that already the majority of both surgeons and cardiologists feel that TAVR and SAVR are at least equal in intermediate risk patients, although there are some that still believe that surgery is the preferred choice in this. Now, the 1-year results of the TVT registry were also published a few months ago, and it shows that the 1-year mortality is about 24%, which is virtually identical as in the pivotal trials. So on one hand, this has been interpreted as saying that the results of the trials are generalizable to the population at large. The issue with that is that there probably has been some risk creep going in the United States, and that these are less risky patients that were in the trials. So maybe it isn't quite as good as if you just compare outcomes versus trials. So this is what's going on now in the United States. This is the STS-ACC TBT registry. 49 of the 50 states in the United States have a TAVR program. I understand there's 20 here in the state of Michigan. We have 22 in Texas. California and Pennsylvania and New York are the other states with the largest number of programs. There are a total of 378 TAVR programs in the United States, plus the VA, because the VA doesn't participate in this registry. And there are also 145 centers in the United States now performing MitraClip. This is the yearly registry, and this is as of June of this year. There were 16,000 TAVR valves done in the United States, and there were about 6,000 done so far for the first actually 4 months of this year. And you can see that the number of patients with undergoing transcatheter valves, or a TAVR valve inside a previously placed surgical valve, is also dramatically increasing, despite the fact that this is not an approved indication for TAVR in the United States. This shows the access site and how it's changed over the years from 2011. And there's two things. So blue is transfemoral on top. It is the line on top. And it's changed based upon different approvals, as well as a decreasing size caliber of the delivery system. And then we can see that it's about 75 to 80% as of the end of 2014 were done by a transfemoral approach. And as I showed in the more current trials, it's getting closer to 90% now that there's 14 French delivery systems available. And this shows how the delivery systems have come down in size from the first one that Cribier used in 2002 down to where we are right now. I don't think they'll get much smaller than this. There probably isn't a great need for them to get smaller, and there would be some compromises that would have to be made in the technology in order to get much smaller, although there are some 10 French delivery systems that are being used in animals right now. Now, is there risk creep going on? I'm going to address this in a minute, but at least if you look at age, it does not look like there's risk creep going on in the United States. The mean and median age of patients now being treated is still in their low 80s, and that has not changed significantly. However, as I also showed in that previous slide, there are a lot of patients in their 80s who are intermediate risk. Their STS risk is between 3 and 8%, and despite the fact in their 80s, they're still considered intermediate risk. I think there is a growing tendency of anybody that's 80 or older should be strongly considered for a transcatheter valve. I don't know whether that's right or wrong yet, but it is kind of the way the world is moving. Now, there are another host of valves coming in. There's 3 more valves that are in pivotal or in IDE trials in the United States right now: the St. Jude Portico, the direct flow, as well as the Lotus valve, and the Jena valve, which is in the middle on the right there for aortic insufficiency, is about to start trials in the United States. So this seems to be a tide that's going in one direction. What are the residual issues on this, and why might it require some modulation of that? So I'm going to talk about stroke, paravalvular leak, need for new pacemakers, durability, and then a problem that's just come up in the last couple months now of leaflet immobility and valve thrombosis. So let's first of all talk about stroke. If we again look at just the partner data, you can see that the incidence of stroke has gone down significantly. And I think that's for a number of reasons. The last group of these series were all examined by a neurologist, which means they have greater scrutiny and the data should be more accurate. And despite looking at it more closely, the incidence of stroke is definitely going down. I think it's smaller delivery systems. I think it's better screening of patients. But stroke does not seem to be the significant issue that it was previously. Now that's clinical stroke. The concern, however, is there neurocognitive disorders associated with cerebral embolization? And what's been determined by diffusion-weighted MRI is that the overwhelming majority of patients, and depending upon the series, somewhere between 70 and 80% of patients have cerebral emboli that are subclinical and not associated with clinical events. However, if you look at surgical aortic valve replacement, the data is about the same. Diffusion-weighted MRI done routinely at the University of Pennsylvania showed about a 75% cerebral embolization rate at surgical aortic valve replacements. So there are 3 embolic protection devices. The one on the left and the one on the right are now in trials in the United States. And through the Cardiothoracic Surgery Network, we now have trials with 2 devices for cerebral protection for surgical aortic valve replacement. This is the results of one of those trials done at a single center in Germany, Leipzig, of a device that goes into the innominate and left carotid artery. And the yellow is the control group that didn't get the filter. The green is the filter. On the left is the total number of lesions at 2 days, and the right at 7 days, and shows that you can decrease the number of emboli that go to the brain by cerebral protection. Now, does this make a difference? Well, this, again, had neurologists see all patients, and these are patients that did not have a clinical stroke at all that was apparent to the clinicians. But when a neurologist sees the patient, you can see that in the control group, there was a 28% detection of a neuro event, and 24% of those, or 24% had ataxia. Now, the ataxia means that you can't put your finger to the tip of your nose afterwards. Tends to resolve, but to me, I sure want to put my finger to my nose afterwards. In the filter group, that was able to be decreased in half. There is this increasing sense in the neurology field that these emboli, they resolve to gliosis, which means small areas of scar tissue. And the analogy has been made to the concussion syndrome in the National Football League, etc. Because there are some long-term neurocognitive deficits that are associated with these early events. If we look at paravalvular leak, that is a large, major issue. Again, I think this is largely being solved both by the new devices as well as by using CT scanning for accurate sizing of the annulus. And you can see this is the incidence of moderate to severe paravalvular leak, and it's down in the 3 to 4% range right now. The need for new pacemakers is a significant issue. Again, this is the TBT registry in the United States. And you can see that the incidence of new pacemakers is up to 12%. That is because CoreValve got commercially approved in the United States. And this is probably underestimating the true incidence of it, because it includes patients that had a previous pacemaker, so it's not really a population at risk, and it's probably actually double this. So I think that is an ongoing issue. There are strategies for placement of the valves as well as the newer generation valves, in which it probably is less. So let's look at durability, which I think is the biggest issue in terms of moving into a younger population. So this is the partner trial at 5 years that showed 2 things. One is that the mean gradient, transvalvular gradient at 5 years was identical surgical versus TAVR. So no early signal of structural valve deterioration. There also was no patient that was reoperated on for structural valve deterioration in either group. Now that doesn't mean it didn't happen. It just means they potentially could have been too sick or too risky to go to surgery. But at least there's no signal at this point. However, I think we have to be concerned because the number of patient years of exposure is relatively small right now. These are an elderly patient population that don't live for long periods of time with their valve. There have been plenty of valves over our careers that looked pretty good, out to 8 to 10 years, and then look what happens in 10 years with the Carpentier-Edwards porcine valve. All of a sudden, the flow seems to drop out. The same thing with the Toronto SPV valve. Looked great for the first 7 years, and then look what happened. So I don't think we have an answer for TAVR yet by a long stretch of the imagination, but at least early on, there is no signal right now of a problem. So let me talk about this issue of leaflet immobility and valve thrombus. So the St. Jude Portico IDE trial in the United States, they used as a scientific curiosity with this 4D CT scanning to look at motion of the leaflets with it. And lo and behold, they found that a fair number of patients in the IDE study had leaflet immobility, and a few of them had valve thrombus on this. They also looked at the control patients, which were surgical patients, and a lesser number, but some surgical patients also had this. They actually stopped the IDE trial to get a better handle on this. And there have been multiple other centers now that have looked at this. So this is a registry that's been published in Circulation in May, thrombus formation following transcatheter aortic valve replacement, treatment of clinical outcomes in transcatheter heart valve thrombosis, an editorial that looks at, does this lead to early structural valve deterioration? And lastly, using CT scan as a screening tool for this. The FDA is very aware of this and very concerned about it. I think we are going to see over the next couple months a lot of issues associated with this. In small series, it happens in both surgery and in transcatheter valve therapy. This is being analogous to the early days of drug-eluting stents and the need for dual antiplatelet therapy. I think we'll see a lot of studies coming up looking what the true incidence is in TAVR and SAVR. Is this device specific or is this class specific? And if so, is either antithrombotic therapy or anticoagulation going to be necessary and help in these patients? I think before it moves into lower risk patients, this issue will need to be resolved. So what are the future issues with TAVR? So one is risk creep. The second is the issue of the heart team. Third is the next trials, and the fourth is what do I think is going to be about aortic valve replacement in 2020. So let's look at risk creep. Despite the fact I said the age isn't creeping down, the mean STS risk score is creeping down. You remember the average risk score in the high risk trials, which is what the approval is in the United States, was 10 and 11 in the two partner trials, and was 8 in the core valve trials. You can see it's now creeping down below 7 median STS score. So I think there is some risk creep occurring, and it's in those patients I mentioned before, 80 years old and intermediate risk. The heart team, I think, has been one of the reasons for the success of rational adoption of this therapy, but I think it is somewhat in jeopardy right now. This is the historical perspective of how the heart team worked. It was a primary decision maker, and surgeons were always fighting back against it. And is this the current version of the heart team? Is it all true lovey-dovey? Well, the heart team doesn't work if this is what it works as. That there is one decision maker and everybody else is pretty much asleep at the wheel. And realizing, despite the fact how well cardiologists and surgeons are working together right now, we still have significant cultural differences, including even in vocabulary. So if you just take this word lead, it means different things to surgeons and cardiologists. Cardiologists, this is lead. Surgeons, especially if you're in Texas, this is lead. So I think that the teamwork has worked quite well, but it is in jeopardy. I've had multiple calls over the last couple months from surgeons around the United States saying, you know what, our cardiologists want to start a new program, but they want to do it without us. What do I do? And he said, you're the ones who've been preaching this heart team and all this kind of stuff. I do think it's under threat right now. I think that as 90% of this goes transfemoral and as a greater percent goes to moderate sedation rather than general anesthesia, and the fact this can be done in the cath lab, it's in jeopardy. But I do think all politics is local, and and I think it's incumbent on every surgeon to work closely with the cardiologist in order to participate in this field. I don't think just signing off and saying that this patient's fine for TAVR is participation. I don't think standing by in another room is participation. I do think it has to be resolved on a local level. It's difficult in many situations, but I do think it's incumbent for the heart team to stay together. The next trials that are coming. So this trial that was published in JACC in April of this year is called the Notion trial, which was supposedly an all-comer trial, again in Denmark, that randomized patients between low-risk patients, supposedly all-comer, over 70 years old, between surgery and TAVR. And the primary endpoint was death, stroke, and MI at 1 year. And you can see that the results were better with TAVR than they were with SAVR. And if you look at this, there are a lot of concerns about this trial. It took 3 years to enroll this trial. Only 14% of the patients screened were actually entered into the trial. So I don't think it's an all-comer trial. Plus, I think if it really was a low-risk population, the surgical results of the 30-day mortality, stroke, and MI of 6.3% is not even what's average in the United States and Germany. So I have a lot of concerns with this trial, but it is out there, and I do think that this is the platform for what's coming next. So, as I said, I think intermediate risk is going to be approved in late 2016. And what's going to be the next trial, or is there a next trial? So there are multiple discussions going on, both by industry, the NIH, and the FDA about designing a low-risk or all-comer trial, TAVR versus SAVR in the United States. And I think some form of that will happen. So what do I think about AVR in 2020? Well, this is how it all adds up in my mind. First of all, TAVR outcomes in intermediate risk patients are promising, as I've showed. I think we should be prepared for an all-comer TAVR versus SAVR trial. By 2020, I think the majority of aortic stenosis will be treated by TAVR. And I think when the intermediate risk is approved by FDA, the floodgates are likely to open, and we will see a shift in the majority of patients being treated with TAVR. So let's talk briefly about the mitral, and I think that there are 3 options for transcatheter mitral valve treatment. One is the MitraClip, second is an annuloplasty, and third is transcatheter mitral replacement. So in many ways, this year is like 2006 in transcatheter aortic valve replacement, but the runway is going to be much longer, and it's not going to be solved nearly as quickly. And for a whole host of reasons you see there's a lot of issues with the mitral valve that are not present with the aortic valve. So these are a list of companies that are looking at this space, over 30 devices altogether. Some have come and gone already, but the number is actually increasing. So if we look at this, there are 2 primary diseases we treat, and I think we should think of these separately: primary or degenerative mitral regurgitation, and secondary or functional. So let's look first at the primary. There's 2 options. One is the MitraClip, and the second is artificial neocords put in by a transapical approach. If we look at the MitraClip, this is the approval in the United States. It's approved for primary or degenerative MR only in patients that are high or prohibitive risk for mitral valve surgery as determined by the mitral valve team. This is the ACC AHA guidelines, and MitraClip for degenerative disease is now a 2B, level of evidence B recommendation. So this is a patient with primary mitral regurgitation. This is a MitraClip being placed under 3D echo. And this is the results of the procedure with trace residual mitral regurgitation. I would say we're treating more and more patients that are high risk, second or third time operation, late 80s, severe decompensated congestive heart failure with MitraClip, and been very satisfied with it. This is the initial results in the United States from the TVT registry that was presented at the ACC. 86% were degenerative mitral regurgitation. It's supposed to be 100, but it was 86%. Procedural success rate means they got a clip in the right position at 92%. A low incidence of complications and procedure results. The in-hospital mortality was 2.3%, and 30-day was 5.8%. This is the worldwide experience with MitraClip. There are 463 centers worldwide. There have been almost 20,000 patients treated with a successful implant rate of 96%. Now look, outside the United States, the majority of patients treated, 2/3 of them are functional mitral regurgitation. Now the other option is a off-pump neocord implantation, and the animation on the right shows the concept of this. You go through a transapical approach, you grab the edge of the leaflet, you bring down 2 cords, and you tether them to the apex on the outside. This shows that procedure being done. So this is a patient with typical P2 prolapse. You can see in the bottom right. And this shows this being treated. So the upper left is the prolapse. The upper right is one artificial cord being placed. This is looking from the atrial side now. On the bottom is a second cord, and then the bottom right is the result with no residual flail. And this is that patient afterwards with no residual mitral regurgitation. I think that it is promising. There's a center in Italy, Gino Gerosa, for those you know him, who has done over 100 of those procedures right now. But I think the transapical approach is somewhat problematic for this treatment. Now, we talk about secondary mitral regurgitation. This is the Steve Bowling slide that, as everybody knows, that this is a disease of the left ventricle and not the mitral valve. And what's never been solved or known for sure, just correcting the mitral regurgitation, change the course of the disease, and or improve the ventricle or improve the quality of life. I think that's a huge unknown in this field. Well, there are the treatment of secondary mitral regurgitation starts with guideline-directed medical therapy, and then resynchronization when appropriate. And then we have 3 options: a undersized mitral valve annuloplasty or the Bowling operation, surgical mitral valve replacement. We have the CTSN trial that shows that that's probably preferred in a specific subgroup, and we have the MitraClip. And now we have 2 more options. We have a transcatheter annuloplasty, a transcatheter mitral valve replacement. So this is a typical patient with secondary mitral regurgitation. What's this? And this is MitraClip being placed for that. You can see on X-plane imaging in the proper position. This has 2 MitraClips placed. And this is that patient afterwards at 30 days with no residual mitral regurgitation. So you can't correct it with a MitraClip. Does it make a difference? Nobody knows. So this is the COAB trial that the FDA mandated be done in the United States as part of their approval of MitraClip for degenerative disease. 420 patients randomized between MitraClip and guideline-directed medical therapy. As of this month, there have been 253 patients randomized at 84 sites. This is a very difficult trial to enroll, but it is an absolutely critical trial in this field because if the results were positive, it's going to open up both surgery and transcatheter therapy for secondary mitral regurgitation. If it's negative, it'll be like renal denervation for hypertension. It'll cause the whole field to pause. So this is a Cardioband procedure by a company called Valtech, which is a posterior annuloplasty, which we know from surgery should not work. It's done by a transeptal approach, and there's a posterior band is placed from trigone to trigone, and with anchors, and then it's cinched down at the end. So this on the left is the animation of theoretically how this works, and on the right is 3D echo showing the band that's in place, and it's being cinched down from the lateral trigone there. So here you can see the anchors going into the annulus. There's a variable number of anchors between 12 and 16 based upon the size of the annulus. And then once that's completed, you go back to the other side, And then under echo guidance, you cinch the ring down until you get the appropriate degree of coaptation, and till the color jet goes away. And this shows this being done. This is baseline on the top, and this is the result on the bottom, and shows that you can completely correct it. And this does seem to be sustained in a small number of patients now, about 30 out to 1 year. So ultimately, you can see that we do multiple things in surgery for mitral regurgitation. This will now be possible by a transcatheter approach of combining an annuloplasty along with a leaflet technology of either MitraClip or neocords associated with it. So I'll move very quickly here now to transcatheter mitral valve replacement, which have been approved for early feasibility trials in the United States. And this is a significant shift for the FDA because for TAVR we lagged 4 years behind Europe. So there are 4 valves that have now been approved for early feasibility trials in the United States. You can see there. However, there's another 8 valves that are in different degrees of development now at the current time. So it's a very crowded space. I'll talk about 2 of them. One is Cardia AQ. It's porcine pericardium, night mouth self-expanding, 2 sets of anchors that anchor it to the annulus and be given and delivered with a transapical or transfemoral approach. This shows the transapical approach on the left. And you can see it's sitting across the mitral annulus there. The valve had just been deployed, and this is the final result with no residual regurgitation and no left ventricular outflow tract obstruction. This is the study afterwards. You can see the valve sits mainly in the left atrium, but again with no left ventricular outflow tract obstruction. This is a second valve called Tendine. Tendine is also a trileaflet porcine pericardium, a self-expanding stent. It's anchored by a tether to the left ventricular apex, and this is done all transapical. But this shows an animation of how this is done. Again, you go through a transapical approach. There's an atrial cuff that comes out, and then once that atrial cuff is in place, it's tethered to the apex, the tension measured on that, and then it's tied on the outside, very similar to the neocords or artificial cords. Once that's in place, this is the tether coming down to the apex and being cinched on the outside. Jesus. So this valve, this shows the results, the before and after of one of these valves, with complete correction of the MR, and this shows the echo of the before and after of this particular valve. So there have been 9 patients done total. The first one was done in the United States in April of 2015, and this one is moving very, very rapidly. Now, you can take a very yawning approach to this and say, yeah, right, this is really going to work. Well, just in the last couple of weeks, this is what happened. Edwards has placed it's actually a $400 million bet based upon milestones reached to purchase Cardia Q. And Abbott Laboratories has purchased Tendine for $225 million. So there's over $600 million now just in the last couple of weeks that's been spent on this space. So like one of the other things in life, if you want to know where the world's going, just follow the money. But this is where the money's being invested right now. So I'd ask you again, a quiz. Does anybody know who these 2 individuals are? The gentleman on the left is Arshad Quadri. The one on the right is George Luger. They are 2 cardiac surgeons who invented the 2 transcatheter valves that I just showed you there. They both became very rich surgeons in the last couple of weeks. The cardiac and CARDIAQ is Arshad Quadri. So again, I think as we've seen with a lot of TAVR, this was a lot of surgeon inventiveness that has developed these transcatheter approaches. So for mitral valve disease, the safety profile of MitraClip will be hard to beat. Neocord is promising but requires a TA approach. Cardioband works surprisingly well despite the fact it's only a posterior band. Transcatheter mitral valve replacement in humans has started. There's been about 50 cases done worldwide, including 15 in the United States now, but there's significant challenges to it, and the results of the COAPT trial will inform the field. To close, I'll finish with the tricuspid. This is the concept of a tricuspid annuloplasty, and this actually is invented by two surgeons also, Francesco Mazzano and Hugo von Ehrman. And so, if you, similar to the mitral valve, if you look at the way the tricuspid annulus enlarges, it's mainly in the anterior and posterior leaflet aspect of it. So the idea is if you create an anchor and bring it to the inferior vena cava, you can plicate the posterior leaflet and correct the regurgitation. So this is their device, which is delivered by the same approach as a MitraClip would be, but you don't have to obviously do the transeptal. An anchor, similar to what you saw with the Cardioband device, is anchored into the annulus between the anterior and posterior leaflet commissure, and then there's a stent that's brought down to the in the inferior vena cava as the anchor, and then that tether is tightened again under echo guidance to be able to correct the tricuspid regurgitation. There are more untreated patients with tricuspid regurgitation out there than I initially thought because they don't cross the surgical radar screen sufficiently. So I think that this will be a field of interest going forward. So, real or transcatheter mitral valve replacement. I think for the treatment of valvular heart disease, the train's left the station and it ain't coming back. And I would say as surgeons, don't get caught sleeping on the tracks because we know where this is going. I think with the mitral, we've got one more bite at the apple here from both TAVR and mitral valve replacement, and I suggest that we take it. Thank you very much.
Dr. Mack will take a couple of questions if there are any. Dan, are you?
Dr. Mack, thank you for that great presentation, and I think all of us in the design surgeon side offer you a great deal as they speak, getting us into this area. The train has left the station. I think it's imperative, as you described it, we not only be a part of the heart team, but an active part of the heart team in terms of really being a piece of these procedures and doing them rather than just standing. I think certainly some of the conversations I've had in terms of the consensus document and the payment. Is there any risk in the future, and what would that do to all of this if all of a sudden you don't need a heart team? You don't need two surgeons to see the patient, particularly as we get to 90% plus for aortic valve replacement, and I presume at some point in time, even though transapical seems to be the best approach for the mitral valve, that will likely become percutaneous as well in some fashion.
So I agree with your comments completely. I would say that what has made the heart team work is not everybody having warm and fuzzies about this. It's because there's a major stick, and that stick is CMS, saying you got to work together. And it's written in the national coverage determination that you don't have to work as a heart team, but if you want to get paid for it, you need to. And everybody, of course, wants to get paid for it. Now, the problem is it's becoming in some institutions just a checkbox rather than an active participation. CMS actually loves the concept of the heart team. They think that this is the first time they see new technology come out and treated in a rational manner. Actually, when the MitraClip got approved and the NCD came out for that, they wanted to mandate a surgeon be in the room for MitraClip also. The way it ultimately got written is could be done by a surgeon or a cardiologist, and we were fine with that because we thought that MitraClip really is a one-person procedure, and if you made a surgeon stand in the corner of the room or begrudgingly scrub in, that you weren't going to make anybody happy with it. But I would also say the institutions where it's worked the best, and there are 6, 7, 8 institutions now in which, including our own, which surgeons are the primary mitral equipment planners. Gora Balawati at the University of Virginia is another, Vino Thorani at Emory. It's working quite great. But the NCD will be reopened at some period of time. It's probably going to be a couple of years before it does. But I don't see the heart team concept going away from that mandate. I think CMS has been extremely happy and feels that that's a big part of it and why this has worked. So again, it's all how it's handled on a local level, but the national mandate will continue to be there.
Mike, welcome back to Northern Michigan.
Thanks, Dan.
It's good to see you up here. Certainly enjoyed your talk as I always do. Quick question for you. Where are we with valve-in-valve, FDA approval? What are your general indications for what you see its role? Obviously, in the context of TAVR, one would think that valve-in-valve would quickly supplant any consideration for reoperation. But let's talk a little bit where the FDA is with this and what about in the mitral position.
So I anticipate that valve-in-valve will be approved sometime within the next 6 to 9 months. Both companies have submitted data to the FDA, as well as there are 2 large registries, the TVT registry as well as an international registry that they have asked for data for. And I think it is such a good option for so many patients that it will be approved. However, there's some caveats to that. If we looked at just the partner trial data, I think that patients that have a size 20, first of all, I don't think anybody has a size 19 valve should get valve-in-valve. Secondly, if you have a 21 valve, the results aren't nearly as good as with larger valves. And I think it's going to be very, very select group of patients that there's 21 valves that should have that. And I think you'll see some FDA labeling that will address that point to it. I do think, however, that this issue of valve thrombosis that I mentioned may occur a little more in valve-in-valves because of incomplete expansion of the transcatheter valve, and I think that issue may be a little more valve-in-valve. So although I think it's a great option for patients that are high risk for reoperation, I don't think it's going to be a slam dunk. Everybody that's got a degenerated surgical valve should get a valve-in-valve for TAVR. I also think that the other consequence of that is we're seeing a significant age decrease, including in our own institution, of bioprosthesis versus mechanical valves for the first time operation. Realizing that you can double the life expectancy of that valve by putting a valve-in-valve TAVR. In that, when it degenerates, I think there's 2 issues with that. As you know, the durability of a surgical valve is directly age-related, and if we keep creeping downwards in age, those valves aren't going to last as long. I drew a blank on the second point I was going to make with that.
One quick additional question, unrelated. When it comes to percutaneous intervention on the mitral valve, and where we're going with whether it's valve replacement or whether it might put I think one important point to see in there, assuming that the COAP trial shows efficacy, shows benefit to actually correcting mitral regurgitation in the myopath and ischemic disease, mitral valve repair of a secondary mitral valve regurgitation is not limited to reductive ring annuloplasty. And both the CST-NET trials only, for the most part, included reductive ring annuloplasty. There are other very effective open surgical techniques that were not considered. So I think there's potential here to skip over very important techniques such as anterior leaflet augmentation, secondary cord lysis, etc., concluding that, quote, mitral valve repair, which is really just a ring, in secondary disease is not effective. I think that's a grave error. So is there any consideration for actually looking at true ischemic mitral repair?
So a couple things. As you know, there have been some secondary analysis done of the CTSN trial, repair versus replacement. And we know that there are subgroups that do better with replacement than repair, such as intravasal aneurysms. I think, however, that if you get a repair and and it does not reoccur, those patients actually do better with repair than with replacement long term. I think the critical information to inform the field is, does correcting it at all make a difference in terms of either longevity, ventricular function, or quality of life? And despite all the years we've been doing this in surgery, we have never answered that question. And once that's answered, then we can delve into all the things about which surgical technique, is surgery better than MitraClip, et cetera. But that question has to be asked first. In terms of actually designing the next trial, I did query the STS database. Take a guess how many patients in the STS database in 2014 underwent an isolated annuloplasty for functional MR.
Do you mean on the mitral valve or all?
My isolated mitral valve annuloplasty, bowling operation, 460 in the whole United States,
The rest of it was mostly
2014.
coronaries though, right?
Huh?
The rest of it was mostly coronaries.
Well, again, just ask the question of how common is the bowling operation used. And it's surprisingly uncommon. I thought at least be 4,000 or 5,000, but it's not.
Thank you.
Robert?
Great. Fantastic talk, and it's obvious why you're a leader in the field, and we're happy that you're out front with both cardiology, professional organizations, and the feds. Two questions following the money. I'm surprised that there hasn't been any cost-effectiveness assessment of the current TAVR trends, because I work in a state that's capitated in terms of expense. Hospital expense really, guides how this technology can be deployed and how often it can be used. So maybe we could comment about any cost effectiveness analysis that might be coming forward out of the database. The other part of it is training. Most of the people in this room, I don't think, have the wire skills to participate in some of these advanced technologies that you're talking about. And getting training to do that, even in our current generation of surgeons finishing, is very hard to obtain. Ultimately, we're going to be boxed out if we don't have the wire skills. So can you speak to your philosophy or strategy about how to acquire those skills or incorporate them into our current training paradigm? Because that's the only way we're going to continue to stay in the game.
So it's a very difficult, very difficult answer, answering the second part of the first. One is, it's been difficult to have it in the training programs because staff and faculty have to acquire the wire skills to begin with. I think the I6 programs, which incorporated time in the cath lab and time in the echo lab, et cetera, have kind of done a better job. And we hired a surgeon out of an I6 program 2 years ago, and she's better than any of our cardiologists at it. I think that the other surgeons that already do have wire skills, of anybody that does thoracic aortic disease, those wire skills exist. And it's not like coronary intervention. I mean, these wire skills aren't all that hard. I'm the one that bought MitraClip to our institution. I took a weekend course on how to do a transeptal, and the rest of it is pretty easy. I think realistically, for most institutions, it's on-the-job training. It's your newest best friend is your cardiologist, and most cardiologists are very open to teaching and collaborating in that. And I think that's the situations in which I've seen it work the best. And your other comment was what?
The cost of the technology and how it's going to be incorporated into the current paradigm. There's no cost effectiveness analysis in the current literature, but we probably will see that sometime.
So there was early cost effectiveness from the partner trial done by David Cohen from Kansas City. And that showed that if done by a transfemoral approach without complications, it was much more effective than surgery or than treating these patients with medical therapy. We've just looked at this in our own institution now just because we see this shift coming. For those of you that are financially involved in your hospital, the highest contribution margin, which means the profit of a hospital, is surgical aortic valve replacement. And what's going to happen is more and more of these patients go to TAVR to the financial performance of a hospital. So we've looked at this very, very carefully, and we see a $22,000 shift in the contribution margin. So TAVR, despite the fact that we send patients home the next day, 20% of the time and that, we lose $7,000 a case.
Very expensive.
Yeah, and the contribution margin for surgical aortic valve replacement, this is all Medicare population, by the way, is $15,000 per case. So it's a $22,000 delta on the hospital stay.
Mike, as usual, excellent. So my question is the national coverage determination. You mentioned how it's been very important in TAVR. Right now, MitraClip is the only percutaneous approach to the mitral valve, and all it requires is a surgery to